And that Vijay madam got sick. I think
Sir, next conference is in Tirupati. You can come and see those places next year.
Tirupati, my temple, my hospital చూడలేదు.
Next year you come to Tirupati, sir. September.
Madhu sir, please start.
Okay. Right. So we are live, sir. I think, Gopal, VVLN, sir, you can start the session.
So good evening to everyone. It is our honor to have today our respected speaker, Dr. Srinivasan, sir. Thank you very much, sir, for accepting our webinar on microbial keratitis. Now, APOS is conducting regular webinars. After Madhu became scientific committee chairman, our society became more active in the last 1.5 years. We congratulate Madhu for regularly doing these things with the backup of Dr. Gopal Raj Garu and other team. And we have a good team of scientific committee and academic research committee members who are active and young enthusiastic members. This is the webinar series 9 today. I welcome all the APOS executive members, ARC members, scientific committee members, and all APOS members and non-members having the opportunity of hearing Dr. M. Srinivasan, sir. So I request Dr. Gopal Raj Garu to introduce Dr. Srinivasan, sir. After that, we can start the webinar. Thank you very much.
Thank you, President, sir. And once again, thank you, Dr. M. Srinivasan, sir. I don't think Srinivasan, sir, requires any introduction. For a formality sake, I think I will introduce, and it's my privilege. I'm one of his students. I'm very fortunate to spend time with him and learn all the clinical acumen and all the cornea-related thing. Were really benefited by him. He was the founder member of the Aravind Eye Hospital group, and then he was the director emeritus. And he started cornea clinic in Aravind Eye Hospital in 1981 itself. And he is the doyen in the field of cornea and eye banking. And he is a worldwide authority on infectious keratitis. Any corneal ulcer infection keratitis is almost synonymous with MS, sir. So then he had several publications and has a lifetime achievement awards at all levels and several prestigious international and national awards at state level also. So with these few words of introduction, I introduce Professor M.S. Srinivasan to our members and this webinar.
Okay.
I will over to MS, sir. Please start your presentation.
Rajesh, you can start sharing the screen, Rajesh.
Yes, sir. Okay. So, respected APOS President Dr. Narsim Rao, Under Secretary Gopal Raju, Chairman Scientific Committee Madhu Raju, and other members of Scientific Committee, past President, President-elect, I deeply appreciate and thank all of you for picking me to participate in this webinar series 9, talking about microbial keratitis non-viral. See this, I just want to, so this slide to emphasize the magnitude of problem that is corneal ulceration, infective keratitis, not only in our country, throughout the Southeast Asia region. In India alone, we see about 1 million new corneal ulcers that is reported to us. I don't know how many we are missing. So to develop or get a corneal ulcer, you should have some kind of trivial injury, corneal operations or fall of dust or whatever it is, 60 to 70%, they get trivial injuries to trigger the ulceration, infection. Contrary to Western countries, we don't have risk through contact lens, not much, very few. And the ocular surface disease like bullous the periodic degeneration, corneal degeneration, dry eye, like ophthalmos, exposure cutaway, all these things again contribute not much as corneal aberration. And corneal surgeries, particularly it is refractive surgery, mostly post LASIK or PRK, again it is not much. So trauma is the major factor in triggering corneal ulceration. And all these years we were talking about farmers or laborers associated with agriculture labor will get corneal ulcers. Now all urbanites who are using biviolets, exposing to dust, they also get corneal ulceration. So when you get like this is such an injury, small penetrating injury, not even penetrating, partial laceration into the trauma, foreign body. It could be a tip of a thorn or a bristle from a branch of a tree. But there is no infection day one, clear cornea, people not involved. But when you pull this, and I routinely put in a potassium hydroxide mount, then you can see the fungus. But on contrary, when you get a rust or a iron foreign body from lathe workers, 1 or 2 days, they come with a small infiltrate. Invariably, it is due to bacteria. So when you have like this vegetable matters, think about fungal. When you have foreign body like rust, you just mostly it goes in favor of bacterial ulcer. So management of microbial keratitis, bacterial and fungal, less than 2% parasitic. The question is, the great burden we have is, in India, we have to differentiate at day one. When the patient presents to you, you have to differentiate between bacterial and fungal. It comes from 50-50. It covers. In Western countries, 90% bacterial, about less than 10% fungal. So they usually start empirical treatment aiming at treating bacterial corneal ulcers. But in India, somehow clinically or by lab diagnosis, you have to day one, you have to differentiate. Otherwise, you will end up in severe complication. Then the pathogens are mostly the universally almost you get same pathogen. It's gram positive, Staphylococcus, coagulans negative, or aureus pneumococcus. That is gram positive, gram negative, Pseudomonas. Then mycobacterial is about less than 10%, nocardia and typical mycobacterium. Even recent papers from UK, the organism that is invading organism or bacteria or fungi, which is responsible for developing keratitis, universally they have not changed. Almost same pathogens you are looking. Bacterial keratitis clinical features. So most of the ophthalmology, except people practicing in practicing institutes or large tertiary care centers, mostly general ophthalmologists, they don't have any other lab facilities. Even if they have to mainly, it takes time. So mostly they are dependent on clinical features. So bacterial, you will get lid erythema, edema, severe conjunctival injection, chemosis, and antechamber inflammation, mostly hypopyon. Sometimes late, you will have endothelial plaque. If it is staphylococcal, gram-positive cocci, single or pair, aureus is more severe, mostly resistant to most of the antibacterial. See, when you see this, the borders you look mostly to well defined. This is what I want you to take note, because well-defined borders mostly goes in favor of bacterial and feathery borders goes in favor of fungal. The hypopion, even though the ulcer is not severe, you can have massive hypopion in bacteria. And again, gram-positive cocci. Pneumococci usually picks up mostly compromised corneas like corneal degeneration, spheroidal degeneration, bullous catopathy, sutured cornea, loose sutured, broken sutured, mostly when they get infected, is pneumococci. And again, the clinical description, one is staging edge, on advancing edge, you have dense infiltrate and a lot of discharge and matted eyelashes. Then this kind of, I think you don't see like this now, it is Pseudomonas called Pyocynia, bluish green. First you get, it's a very severe ulcer. You can get like this even within 2 to 3 days of any injury, or patients who are treated in ICU or burns wards, they may get like this, or they would have applied some native medicine. And not many, but many cases, they may end up like this. It is severe Pseudomonas infection. So mostly we are dependent on clinical diagnosis, because any bacterial, any microbiological lab, if you send specimen, even best lab, you get positive culture only in 50% of patients. And if you do gram stain or KOH may give more positive in fungal ulcer, not in bacteria. So you are still dependent on clinical science. If you are dealing a bacterial ulcer, you look at the lid. Even 48 hours, you will get lid edema. Then metastasis. And then you press lacrimal sac. Always in South India, when any patient gets corneal ulcer, you have to rule out cystitis. It's just raw blast test. You get such a large discharge. It could be mycopus or just pus itself. It speaks for pneumococci, there is no doubt. And this kind of well-defined border, hypopion, discharge, again, it is in favor of bacterial ulcer. This patient is 48 hours, Pseudomonas ulcer, contact lens wearer, he is a college student, and weekend they went for a tour, and 2 days he has not removed the contact lens. He landed like this. When you have mucus like this, invariably it is bacterial, particularly Pseudomonas. At switch time you clean this, in another 10 minutes, again you will get like this. So this is mostly goes in favor of Pseudomonas. Then you choose an antibiotic to cover Pseudomonas. And again, I want to emphasize that borders of the cornea, so much hypopion, such a severe ulcer. Look at the border, again, it's well defined. You can have stromal abscess, deep abscess, all those things. Hypopion may be solid, but you look at the border. So most of the cases you can find out this difference. This is bacterial, this is fungal. So slit lamp examination mostly helps to have early diagnosis of corneal ulcer. Then how will you differentiate bacterial and fungal? Solve the panel into your left side. This is typical early fungal ulcer, 3 days or 4 days duration, injury with maybe all of dust or any vegetable matter. They come with 6 vision. See, the people is now no edema. This most, even my own consultants here, fellows, they are always confused with ventricules. 90% of them, they diagnose it as the early dendritic ulcer. They start with antiviral, sometimes steroids. So if you stain this, it won't take up stain because the crater is filled with exudate. But when you stain a dendritic ulcer, it nicely stains, and you can see that terminal bulbs, all those things. Then again you see little advanced ulcer, again you see the borders. Then even large ulcers with hypothesis, you will see the borders. Pardon? So this clinically you can pick up very easily. Then bacterial ulcer, whatever may be the size, still you look at the borders, they are well-defined borders. Massive hypopion, well-defined borders, pneumococcus, advanced edge. So then you see that bacterial ulcer, you will have scrub. Then this is early perforating bacterial ulcer. So clinically, most of the cases you can make easy diagnosis of, you can differentiate bacterial and fungal. And what about lab diagnosis? Many of us may not have access to lab diagnosis. Even if you have lab, you need a technician trained in aquatic microbiology or microbiologist trained in aquatic. Otherwise, the specimen is always very small, unless this is very large ulcer, so you have a lot of material to scrape. But most of 2 millimeter ulcer like that, when you get very little material for smear, either KOH or gram stain, unless they are well trained, they will miss it. The gram positive, gram negative, but it takes, if you have multi-specialty hospital, if you have facility, you may get it in 30 minutes or 1 hour, then you can start diagnosis. But if you mail the slide, it may take 1 or 2 days. Then KOH gives very nice septate pointage, 90% sensitivity. I strongly believe in KOH. If you suspect fungal, you scrape, and if you have facility, you yourself look at the light microscope, especially binocular microscope, you will pick up very nicely. This is very important nowadays. This step will differentiate between fungus and pythia. That is very important nowadays. That's a big issue. So the pythia will mimic like fungus, but somehow you have to differentiate. This is Graham's or Graham's septum. You can very nicely see in KOH. So this sometimes you may have so much pus, but you may not get anything. This may be just sterile pus makers. So mostly clinical diagnosis, then you can go for smear. And when you ask for culture, this is most academic exercise, or some patients you are treated for a week, not responding, then you may order a culture. And we routinely use blood agar and PDA or several agar to rule out fungus and bacteria. The other things are just for some research purpose, or you specifically ask for this chocolate agar, launch intention medium, non-nutrient agar for acanthamoeba. It's not routine, but in our hospital as a teaching institute, and a lot of projects are going on. We take KOH smear, gram stain, then blood agar, and this one, Sevrats or PDA. So this takes, sometimes bacteria grows in 3 days or 48 hours. Fungus may take 7 days, more than 7 days. So you can't wait for that. Whether you treat or I am treating a patient, I have to somehow commit to go for empirical treatment, topical, subconjunctival I don't give now. I was giving earlier gentamicin, cephalosporin, vancomycin, all those things, but it's so painful. In private practice, we can't do this. Topical, we have now powerful broad spectrum antifungal. Intrasomal, some people they give voriconazole intrasomal in fungal ulcer. Intracameral also, they give amphotericin B. And oral and parenteral, I don't give for, even for fungal ulcer, I don't give oral, but many people they give for deep fungal ulcers or after therapeutic graft or when they get endophthalmitis, but I don't give. It's very toxic drug. So if you read some of these latest articles, most of the bacterial ulcers, they respond to the traditional empirical therapy. And methicillin resistant staphylococcus, if it is resistant to methicillin resistant, it comes, it will be resistant to all antibiotics. But in my practice, In vitro, the lab may say it is resistant to commonly used antibiotics, but when you use concentrated drugs and frequent applications, I have seen the answer is responding. So you have the lab report, but if you see your patient is responding to your empirical therapy, you just continue it, don't stop it. Only thing is, see that they are the frequency is same, concentration, they are not confused with bottles and all these things. Sometimes they misuse. And in large ulcers, I just apply atropine or prescribe atropine. Homatropine may not dilate the people. And this is from east of England. They have found out any change in the pattern of offending organisms in that country also. Gram positive and gram negative, mostly Staphylococcus, pneumococci, and Pseudomonas about 30%, gram positive about 50%. So the offending organism is same. Sometimes they may develop resistance to this. Then how do you select topical agents? Broad spectrum to cover gram positive and negative bacteria. Macrolides we don't. Polypeptides also like bacillus, neosporin we don't use. So I commonly go for aminoglycosides acids and fluoroquinolones. Aminoglycosides acid, gentamicin and topramycin, rarely amikacin. Gentamicin gets toxic to cornea. Fluoroquinolones, you can go for second generation, Cipro, third generation, fourth generation. Still Cipro, even though there are few peppers quoting Cipro, many organisms, especially Pseudomonas, resistant to Cipro. But I have seen it works, really it works very well, particularly when you remove a corneal foreign body like rust or small stone debris or something. Instead of going for fourth generation, you can still use the Pro. It really works. And off-label drugs, mostly for bacterial like vancomycin, cephalosporin. Cephalosporin is not available now. We go for cephalosporin for gram positive. Vancomycin definitely for gram positive with pneumococci. You can start 5% vancomycin off-label drugs for bacteria. So cephalosporin still drug of choice. But cephalosporin was very good, but it's not available now. So we go for cephalosporin, ceftazidime for gram negative. Aminoglycosides, I go for topramycin. And some resistant Pseudomonas, if you suspect already they have been treated with topramycin, it's not responding, gentamicin, then I go for amikacin. Amikacin commercially 1% available, but I would like to prefer 2% amikacin so that it really works. Then fluoroquinolones, Moxie is now commonly used, frequently used. You can have levofloxacin, getafloxacin, moxifloxacin, besifloxacin. The principle of action is almost same. And severe ulcers, I just go for sometimes combination. And what about monotherapy or combination? Combination, if it is gram positive, I go for cephalosporin. Then I combine with some topramycin or something. For gram negative, I don't give combination. Mostly I go for fluoroquinolones, second or third or fourth generation. But there are so many Indian companies, they make fluoroquinolone, polymyxin combination, all those things. But in severe ulcers, I usually prescribe Vigamax or Thymax because Vigamax, same thing, moxifloxacin, but when you have very active ulcer, at least for a week, I use prescribe Vigamax or Thymax. Then once it starts healing, then I go for regular Moxi, what you get here. Frequency, mostly severe ulcers, we just waking hours every hour, at least for 48 hours, then taper it 2 hourly, 4th hourly, according to the patient. And usually we don't admit, but if it's severe ulcers, if you have inpatient facility, you can admit them. Termination for bacterial ulcer till it heals, maybe for a week. For fungal, you have to use 2 to 3 weeks more after healing. Parenteral antibiotics, I don't give unless you get clearer involvement or endophthalmitis or you are implanting a surgery. Parenteral, mostly like aminoglycogen, like gentamicin, IV, vancomycin, I have not used it. Other routes, some people they soak in contact lens and then they apply, and so you can try if you want contact lens soap solution. So this is just one case already told. This is the contact lens wearer. I got gram-stained Pseudomonas, culture also grew Pseudomonas. So I just started just to become a monotherapy every hour. This third day, this is 1 week, completely healed. So there is no bargain to try this. I just hit with the strongest antibiotics. A very young patient, it really healed. Even severe Pseudomonas, the 10-year-old boy Pseudomonas, in this patient, I combine both fluoroquinolones and amikacin, 2% amikacin, and really it heals. Whatever severe Pseudomonas, if they come without perforation, somehow we can kill it with fluoroquinolones, amikacin, or tobramycin. But in some cases, you sterilize the ulcer, but still you will have hypopia and such a large epithelial defect. The ulcer has not healed, even though you have sterilized the corneal ulcer with Pseudomonas. So in these patients, I use steroid under cover of antibiotics, same antibiotics. Steroid 4 times a day for 5 days, then 2 times for another 5 days, and really works. Maybe Pseudomonas. So you have treated this, then you wait, doesn't heal, you get neurotrophic adjusting, and this is 7 days after steroid, then it nicely heals. So steroid has a role, particularly in central large ulcer due to Pseudomonas in our study, it really helps, but not in every case, not in fungal. Then nocardia is forms about 6 to 10% of our total corneal ulcers. Actomyces is very rare. Actomyces you get in mostly for patients with canaliculitis, chronic, bilateral, you suspect actomyces. But corneal ulcer due to nocardia usually following a fall of dry soil when the patient, when they do weeding or something in cotton field or other like chilies or something, the soil must be dry. So when it spills into the eye, invariably they get nocardia. Very easy to diagnose. This is a typical clinical picture, faded appearance. You will have hypopia. This is 100% you can diagnose clinically when you see like this, faded. Then gram-10, you will have a lot of gram-positive filaments, bearded appearance. And just for academic exercise, you can culture it. Even it grows in PDA. It takes time. But at this stage, you can diagnose. And treatment is fluoroquinolones, Cipro, they don't work now. So I go for sulfacetamide, 20% solution, it's available. Or dimethaprim, it's not available now. It's a very good drug. Then if you don't get that, you start with directly day 1, start with amikacin 2%. It really works. Really it helps. So usually they don't perforate. Very rarely we do therapeutic graft. In some cases, on this year, I had 2 patients resistant to amikacin and sulfacetamide. Then you start ampicillin, injection ampicillin, make it a 5% draft. It works. Then Mycobacterium, which again is very rare, mostly follows trauma and surgery, either radial keratotomy or keratoplasty or corneal surgery. This case is a doctor, had cataplasty. After 70 days, they come like this. Patient is already on steroids. And this, we just scrape and culture also. We could get the gram-positive bacilli, mostly mycobacterium. And eventually I found out this was from the donor cornea from a particular eye donation center, then published a cluster infection. I think I had 8 or 9 patients. You don't get immediately. Then recently I get post PRK. The patient comes, they are fine, 6 weeks revision, 3 weeks, you stop the drug. They come after 3-4 weeks or 5 weeks, then red eye, sometimes bilateral, focal infiltrate, then you suspect this. So it's very rare. Other infections, bacterial, fungal, you will get in a week, even nocardia get in 1 or 2 weeks. But this one, post PRK, post LASIK, sometimes you get after a month, you always suspect. Here the treatment is amikacin. Amikacin, it works, it almost creeps from one end to other end. Then eventually it heals, but then unusual clinical features like this. So marginal infiltrate, saturate lesions like this, and it is a contact lens whether you are terribly confused whether you are dealing infected ulcer or immune related. It's very difficult to find out. And this is the right panel. Again, you see, you just examine under slit lamp. If you have lucid interval between the limbus and the lesion, or the lesion, uniformly, it could be like a Plicton or Plicton keratitis or fascicular ulcer. But if you see that different clear space, then you are dealing with a staphylococcal marginal keratitis, immune related. You start with steroids antibiotics. But here it is very difficult. Whether it is immune or infective, very difficult. You have to try first antibiotics. Then it doesn't work, then you can ask some steroid. Because it's too small to have culture out. Then post cataplasty, either article or therapeutic. When you get some loose sutures, when you get infection, invariably you are dealing with a pneumococcal, mostly pneumococcal. Post cataplasty after 6 months, 1 year, patient comes with a broken sutures, red eye, focal infiltrate. Then always you remove the sutures. If you want, you do gram stain or culture. Invariably it's pneumococcal. You start with ceftriaxone or tobramycin, whatever drug which covers it heals. Then if you get like this, immediate or after 10 days or after 2 weeks, then it could be from donor or you have not covered the entire infected area. It's too big. So it could be, now you can do KOH or gram stain, it could be fungal. So these things now you don't see very often, but in a teaching center you may see when you do 200, 300 cataplasty, mostly therapeutic, you may get like this. So these are rare presentation. These patients, you look at you always look at the other eye. They may have old nebular lesions near the limbus. Then you go for fungal ulcer. So you see all the slides. You don't miss this. This is typically to look like dendrite, see like this. But this is typical dendritic ulcer. You see that it's very difficult to differentiate. But the crater will be filled with the exudate. It will be grayish white or yellowish white, it will be filled. But typical dendrite, you just stain, you can see the terminal bulbs. The crater will be gray. That is the clue. So this is 100% fungal, this fungal, immune ring again, you further bordered, massive hypopyon. All these things, you need not go to a lab. Day one, you can diagnose as fungal, you start antifungal. And 10% of patients you may get pigmented fungal ulcer. It's very difficult to scrape. And also, it takes a lot of time to heal. Even natamycin doesn't work. You have to go for clotrimazole or other things, imidazole. So this doesn't perforate quickly, but doesn't heal quickly. This also you have to suspect. To look like iris prolapse with fungal, pigmented fungus. So clinically, it's a routine exercise. I strongly believe in 10% KOH, 90% you can pick up fungal, not bacterial. Gram stain is all. So routinely we send that 2 slides for KOH and gram stain. It just adds your diagnostic skill. Then all the stains, some institutes they use cytokinol. In Calcoflower nowadays we use with gram stain or KOH to differentiate pythium. So these are some of the pigmented fungi, Dermataceous, Carularia, Trichelera, all those things. This is flight culture, takes about 2 to 3 weeks to get this. And you need not wait for this. Then medical therapy, fungal, we have only approved medicine, we have only natamycin. Natamycin works, in our study we have found works. Most of the patients, up to 70% for Fusarium keratitis, doesn't work well for. Then South India, we get Fusarium as number 1 and North India as plus 1. Candida is very rare. You need not worry about Candida. Then routinely we use natamycin. It's available easily. Every hour you have to use for weeks or months, and you have to reassure the patient. Oral, if you want to, you can give ketoconazole, fluconazole people are giving. And fluconazole are very toxic drug. Some patients, they get sleepwalk, suicidal tendencies, other problems, so I don't give. Voriconazole, you can give topical, oral injection, but my preference will be natamycin. And newer azoles like posaconazole, it's not available as ophthalmic preparation. Mostly it's available as tablets and injections. It costs about the tablets one strip will cost about 10,000, 12,000 rupees, and even injectable form. So we don't use like caspofungin. I have one report. They use 0.5%. Again, caspofungin is available as injection. That is powdered vial. You dissolve in water for injection, and you make it is a 50 milligram vials available. Make us 0.5%, and there is only one report in Fusarium they have tried, and other things I have not tried. So this voriconazole available, and again it's not ophthalmic, it's injectable. RRB is making, and once you have tried natamycin, amphotericin B, it's not working, then you can try this, or you can use as adjuvant therapy. Surgical treatment of micro perforation, small perforation, you can try tissue adhesive, bandage lens. Conjunctival flap, I rarely do now. Tectonic graft, sometimes you need. Lamellar for fungal, mostly you get reinfection. Even if deep lamellar, it's very difficult to eradicate fungus, deep fungus. Even desmoids will get infected. So always, if you go for therapeutic graft, go for full thickness graft, cover all the infiltrate, then continue antifungal. Don't give post-op steroids or cyclosporin, all those things. Our aim is to make the patient comfortable and retain the glow, not for optical. Optical you can think about later. Evisceration, we don't do it. We just tell the patient, you just go for all the medicines to continue. Sometimes give oral antibiotics or antifungal. So for just to avoid litigation, evisceration and enucleation we don't do unless you have intraocular tumors. And the acantha amoeba rarely we see is about 2% of the total corneal ulcers. we first reported from India in 88, a non-contact lens related. The West always report following contact lens, but here we get like any other corneal ulcer following any trauma, you can get acanthamoeba. So if you culture contact lens storage cases, 2 to 15% of storage cases will have contamination with acanthamoeba. And sometimes if it is through contact lens, sometimes you may get patients with bilateral acanthamoeba. It is very difficult to pick up early cases. Very difficult. Contrary to Western literature, Western mostly 90% contact lens related. But in India, still it is trauma, contact lens only less than 2%. And mostly acanthamoeba patients are young patients. They are not immunocompromised, all immunocompetent patients. Most of the fungal ulcers also maybe 50% diabetic, but most of them, they are not immunocompromised. There are no etiology. This is radial keratonitis, early sign, but I don't see them very often. It's only because unless they come early, or in Western literature, they describe radial keratitis very often, maybe due to contact lens wear, I don't know. But in our cases, this is the typical clinical feature of acanthamoeba, mid-stroma and mid-periphery of the cornea. We just see a normal ring. Sometimes you will have hypopion, solid hypopion also. And first visit, we always, all of us we miss. It's very difficult to diagnose. And you strongly suspect when the patient already used medicine for bacterial ulcer, fungal ulcer, all those things, still it's a month, more than a month, not perforating, patient is symptomatic, then you go for, you think about this and you start treatment. Even KOH, you can see acanthamoeba in lactophenol cotton blue, this in the lab, but clinically you have to go by sign. The treatment we use chlorhexidine, 0.02%, and the current report latest by John Dart, all those people, they are authority in acanthamoeba. UK is very common. Now they are using 0.08% PHM. So, and they have found 80% of the patients, they heal very well. So now the treatment of choice is monotherapy, PHMB, 0.08%, but still we are using 0.02%. The PHMB is, I think, ROLab is making. If you order or request, they will mail to you. And it's a 20% solution. And I think we don't have access to pipettes, not to have 10 microliter. But I read yesterday, if you don't have microliter pipette, you just have a glass rod, dip into the parent solution. You have one drop into the sterile oil, then you add 10 cc distilled water, then it will give required concentration. Then treatment is done for 2 to 3 months. So you don't expect results in 1 week or 2 weeks. You tell the patient and insist them to continue the treatment. Mostly they may have vascularization, thickening, but I have not seen any adverse events. But recently, this miltefosine, this just for academic exercise, the drug for leishmania is a very toxic drug. For a patient, they have spent 2 patients they have treated. Each patient got $10,000. This is for 4 weeks treatment. I won't suggest this. This is just for completion, I am just telling. Then microsporidial, all conjunctivitis throughout the year we are getting in Madurai. I don't know, throughout Tamil Nadu. I treat as microsporidial keratoconjunctivitis, not adenovirus. It mimics like anything, adenovirus. They will have SPK, duck-on appearance like this, very coarse, unilateral, bilateral, membrane, chemosis, retrodema, periauricular node. It will typically mimic adenovirus. Many people, they come with antiviral, steroids. Now, every case, conjunctivitis, daily 2 or 3 patients I see, Initially, Southeast Sarma, all these people, they reported related to a rainy season. It's not like that. Throughout the year, you get any age group, you get, may not be immunocompromised. So you just, for academic interest, you just take it as a beaver blade or your sterile cotton tip plate on a side and look for gram stain, you will typically get this spore. So this responds only to fluconazole or itraconazole. So many people, they use all kinds of antibiotics or antiviral, never responds. Run for 2 weeks, 3 weeks, unilateral, bilateral. When you see like this, any conjunctivitis, there is no harm in using fluconazole. It's readily available and commercially available. That is it. Then last thing is a dreaded infection. Unfortunate to have this. Very difficult to differentiate between this and fungal. So after seeing hundreds of patients, I have come to some clinical features to diagnose, like tentacles, wedge-shaped ulcer, a crater like this. Mostly it starts in the periphery, and all these ulcers we missed because when you scrape and do cave white or gram stain, calcoflower white, it will typically mimic like fungus. See, so you will have this, all the filaments like mycelia. One difference is you will have the septum in a typical fungal ulcer, fungal keratitis. Here, septum is sparsely present, and the caliber of the filaments will not be uniform. It will be like a noodles, tapering, and it readily grows in blood agar on third day. It doesn't grow in PDA. And treatment, I believe in mostly itraconazole. This patient with proved pythium keratitis, this kind of like a Dillon-like crater, and you see the edges are very thick, heavily infiltrated, but compared to the center of the cornea. And I start itraconazole every hour. This is after 3 months. So 6 or 7 patients I use itraconazole, it healed. But there are other institutes, particularly LVP and other people, they strongly believe in using linezolid 0.2% and azithromycin, and they claim, I won't say better results, you can reduce the patients going for therapeutic graft. Instead of 80%, you can cut down to 40%, but still mostly it perforates. So this is not rare, we are getting now. Mostly you can diagnose clinical and antifungal, you don't have any effect. Poor outcome. So I use itraconazole. Sometimes I combine with azithromycin, topical drops or ointment. Itraconazole also you can give. That is my routine practice using itraconazole. It's readily available commercially. Linezolid, it is IV preparations available as I think 200 milligram multi-dose like a vial. From that you can pick up and dilute to 0.2%. That is 20 milligram per ml, I think. I think 2 milligram per ml, you can directly use it. But I don't have high confidence in this, but other institutes they are using. So then these are the things: collagen cross-linking, rose Bengal, photodynamic antimicrobial therapy. These are the things people are trying now in institutes, but doesn't work for deep fungus. And this for bacterial, it may work, but you need all the facilities to do this. This is just for completion's sake I am presenting. We are doing a project, and this is for patients who are not healed in spite of all your efforts. Then you try this. Then this current diagnosing, molecular diagnosis, PCR disadvantages, you will get false positive. It won't pinpoint what organism you are dealing. Confocal help for fungal and acanthamoeba, not for bacterial, ASOCT. All these things are available. This is acanthamoeba, this is fungal. You need the confocal microscope. This you don't get this. So as a general practitioner, you are mainly dependent on clinical diagnosis in the first few days, and you pick up whether it is bacterial or fungal, and you just commit, start monotherapy or combination, and mostly it heals. And nowadays they are having a lot of clinical pictures, artificial intelligence. In future, you load your corneal ulcer, take a picture in a mobile and send it to, and you will get an answer whether you are dealing like microbial keratitis, that is bacterial or fungal keratitis. Then it will help how to start the treatment. So even though current diagnostic facilities are available in most of the institutes, management of corneal ulcer mostly depends on clinical diagnosis. So careful clinical examination is crucial managing any infected corneal ulcer. I feel role of general ophthalmologist has a lot of significance in preventing corneal blindness in India. Think about 1 million corneal ulcers, 50% they go blind due to corneal scar or 1/3 is perforated. So 20% of all corneal ulcers, even in institute, end up in therapeutic graft. Thank you very much for giving me this.
Excellent lecture, sir. Excellent lecture, like always. How many hour times we listen to your talk? We always get new points from your each talk every time. I have almost written 3 pages of notes from what you have told. Sir, sir, regarding this pneumococci, sir, you told in compromised corneas we see them.
Yeah.
What would be the drug of choice, sir, for pneumococcus?
For Nemo, I was using cefazolin.
Sir,
It really works, but cefazolin not available.
not available.
Cefuroxime 5%, the color changes. That's why I have doubt. I don't know whether shelf life is good or not, but we present, that is prepare 5% solution. Shelf life 1 week. You can keep it room temperature. You need not have a refrigerator.
Okay.
Or vancomycin is very good. Vancomycin also available, 5% vancomycin.
Okay.
Then tobramycin, it also works. Tobramycin covers both gram positive and gram negative.
Gram negative. Okay, sir.
But you rule out dacryocystitis. If there is dacryocystitis, unless you remove the sac, you will never
Yeah.
heal.
Until unless DCR, yes, sir.
Especially in South India.
Yes, sir.
Sir, there is one question, especially in fungal keratitis, the patients invariably complaining of severe pain at the night time. It starts in the evening. What could be the reason, sir? Any specific?
See, pain is mostly subjective. Most of the patients always complain. So unless even small ulcers they have seen, they complain pain. Only secondary glaucoma, invariably they will get secondary glaucoma. Very difficult to do the tonometry or anything, only digital. So second, you can give Diamox or FRSR if there is no contraindication. I tell them to have after 5 o'clock or after dinner or something to take a pill. Whether you get pain or not, they can take. And invariably they get. We have to give powerful analgesic. There is no other way. And some people they go to general practitioner. They get injection also for pain. So this we can't blame them whether they are exaggerating or not. We don't know. It is your patient. When they complain pain, we just tell them. Invariably they go with powerful analgesic, 2 tablets per day after meals unless there is contraindication. And secondary glaucoma is one of the commonest cause for severe pain.
Yeah.
Sir, one question. In bacterial keratitis, before you get the culture or diagnosis, if you want to start fluoroquinolones, Vigomax and J-Maxid, which do you prefer?
That's why, so I don't want to combine the, the Indian companies also make. Same Alcan, Alarcan, they make in the US, they are making in Bangalore also. I have discussed with them, same product, same manufacturer, why this works in severe infection doesn't work. Maybe the quality of the product, because there they are selling for $80, $90. Here you want to have for 150 or 200 rupees. And they have to somewhere compromise either penetration or shelf life or bioavailability of the drugs. So whenever like endophthalmitis or severe bacterial infection, first few days I want to hit it with. This is available. Cost is also it is not different. The Indian Maxi also now they are selling for 200 rupees. Bigamax are about 300 rupees. So it is not like antifungal we are going to use for months, just for a week. It's what, so I always prescribe day one with the bacterial, especially Pseudomonas, contact lens related, young students, IT%. So it's not scrapable. Less than 1 millimeter contact lens. I don't know immune related or not. It's better to hit with Thiamoxide, good for gram positive.
So
Then
yeah.
after once you get response for tapering or to continue, you can go for.
Yeah, I think one more.
Yeah.
I think one more practical tip that we all have learned from MSR is he puts the first drop in the clinic itself. He has all the antibiotic and antifungal ready with him.
Demonstrate that relative.
Yes,
See,
sir.
many patients they apply ointment over the lids.
Yes, sir.
Even today morning, I have patient. They get many people they give antibiotic, maybe homotropium doesn't work for carnal ulcer. Atropine or homotropium, they spill into other eye also. Then invariably they give for irritation some lubricants. So today patient came, he came well dressed into antibiotic cartons, then antibiotic into the well drop. This is daily I get a patient like this. So whatever, you may be very busy, but only thing to convince a patient, we know whether you treat or I treat, they are going to end up with a corneal scar. They may get 50% vision or 25% vision. But to satisfy the patient, get the drug. You please look at the drug. They will say every hour, but they would have not even used 1 ml for a week.
Yes, sir.
So this you have to find out why it is not healing. Whether they have changed the medicine change means
Compliance medicine.
when they apply, they just change the cover. So that you have to see. Atropine, you yourself apply once, it dilates, it's okay. Or very severe fungal, you have to prescribe ointment. Better ointment, not drops, because many patients, their attendants also, they applied atropine because when they get something, like irritation, foreign body, they apply homotropium and atropine. They just come. And nowadays, drops used for pain balm, for low backache, and I saw other day for some other pain. Typically mimics like ophthalmic vials containers.
Correct.
And tube also typically mimics like your Acupal Neosporin ointment tube.
Yes, sir.
So even every week I get like they have applied this and they come. So please, in your practice, you just at least once take the medicine, tell the attendant how to apply the ointment into the eye.
Sir, during your those days, you used to tell that acanthamoeba in India, not from contact lenses, you used to tell us that the people working with the groundnut farms, And also the people who uses the pond water for washing their face. So you used to tell us that
Mostly groundnut mostly goes in favor of fusarium. But water mostly from that, we don't have overhead tank. Europe is very common. Here, anything when they are irrigating the land, right? So summer, now the water gets very hot. So end of the day, they wash their face, and the water may have. So once you get abrasion, you get into that.
Yeah.
So that's a
Madhu,
good.
Madhu, please go ahead.
Huh?
Madhvi is asking something.
Yeah, I just had a question, sir. Sometimes, thank you so much for such a lucid talk and extensive talk. Like, it's always a dilemma when you have a corneal infiltrate or an ulcer. So, sir, sometimes we come across a picture not very clear cut of a fungal or a bacterial, a combined sort of picture, because patient would have already used some drops and come, and we may not be having access to immediate microbiological report. So in that scenario, can we give a start of a combined therapy and then
That's why I am telling scientifically wrong. But
Okay.
most of our doctors nowadays, they combine moxifloxacin and natamycin. All the patients go with 2 bottles. But scientifically, it's not. See, when you kill bacteria, you are promoting fungus, natural flora. When you kill fungus, you are promoting bacteria. They have symbiosis. So synergism is there. So there's an article now recently. The normal ocular flora, you have Staphylococcus, rarely Pneumococcus, rarely Pseudomonas, and sometimes Candida, not filamentous fungi. So once you suppress one thing, other thing will grow. But many people, they are just to cover up.
Yes.
So that you can escape. You can tell the patient, see, I have given both drugs to cover bacteria and fungus. So in the future, suppose somebody is blaming you that doctor has missed this, missed that. You're able to cover up, that's what. But scientifically, it is not right. But many of our doctors are using now. It's a routine practice now. Prescription, 2 drugs, they go.
That's why the doubt, sir, because we don't, they keep like
no,
they're already using. So to withdraw a drug, we are also in a dilemma. Should we withdraw the
Dilemma, yeah.
antifungal and continue only with the antimicrobial? That's a.
The clue is
Ramesh Babali, sir,
already,
you want to add?
already patient is used.
Adding, I have a question. Recently, I have started seeing different type of microbial keratitis.
Okay.
Actually, it looks like epithelium only. Probably recently, this from 10 days or 20 days, probably.
Microsporidial, sir, you are seeing?
Yeah, it looks like microsporidial. How my question to sir is how to differentiate between microsporidial and pythium, and how to treat them.
See,
Viral.
microsporidial, the duration is just patient will come in 2 days. Severe conjunctivitis, mostly bilateral, sometimes unilateral. And you look at the split count, you will get SPK. Most of the patients report SPK. Sometimes you will have fine silvery white descent line,
Yes.
white capes. It's you will get like this also. But pythium, they come to you after a week or already treated elsewhere. Pythium very difficult to pick up helicase. And the tentacles, all those things, it gives a clue. So only thing is you can confirm through scraping or culture.
Yeah.
Clinically, you can suspect what I have already described. Tentacles, crater, then prolonged duration, not responding to antifungal, all these things they give clue. See, if it is Pseudomonas, the cornea doesn't stay there more than a week. Not that it will perforate. But fungus and pythium will buy time, takes time.
Yeah.
Spread and perforate, go deep and perforate, unless they are very, very bad diabetic.
Yes, sir.
Microsporidium, we are getting Every day, all my conjunctivitis nowadays, I just give glucosate, autoflu, glucan, all available now.
Sir, this microsporidium, are you seeing any seasonal variation, sir?
No, that's why I told. Savitri Sharma, all this when they initially they said in Orissa during flooding area they had
Yeah.
epidemic. No, it's a throughout year you get. They are not
Throughout
getting water source. Most of the students come. It's
Yes.
not family. 4 or 5 people they get. Whole family they are getting. And they already used steroids, antibiotics, all those things. Doesn't respond. In a week it responds nicely. And if they come with severe lid edema, chemosis, parotitis, biliauricular node, then I give, apart from fluconazole, I give oral ciprofloxacin just for 3 days, then Serratia 50 days, things like that to reduce the edema, Camiflam or Serrated D. I don't know how it acts, but when they come with such an edema, patient will be terribly alarmed by the picture. They can't open. So I don't know how Cipro works. I give oral just for 3 days, just to satisfy myself.
Sir, is there any role for oral doxycycline in corneal melting, sir, because of the infection?
Yeah, because doxycycline, see, melting is mostly due to the enzyme. That's why in our study we started steroids after
Right.
stabilizing the ulcer. Doxy also, it works. It prevents melting of the stroma due to the enzymes released from PMN and all those things. There's no harm in giving.
You know.
Even graft rejection they are giving.
Doxy, yes.
Doxy. You can
Sir,
give doxy.
Sir, during my initial days of practice when natamycin was not freely available, I tried the powder of the ketoconazole tablets. Mixed in that also used to work well.
Yes, now because Arolab is making, aerosol is available, is well, but only the only problem is all oil based. Peanut oil, burning like anything. Many patients they complain severe burning. Protimus also Aroclat. Aroclat I prescribe specifically for pigmented point. Very cheap. So tablets you can crush it without opening. I used to crush with a glass tumbler. I roll it nicely powder. Then you put it there. The thing is you should have a sterile vials. Cytokine vials or there is so many vials, animal vials. Should be autoclaved, should be readily available. Or you mix with any. The unfortunate thing is now artificial tears, everything is coming in PPM. So you don't have the glass vials to open and previously we used to have a MySAG, methyl cellulose open and put. Now you don't have any glass vials. So you can have maybe voriconazole vials, you just sterilize it by autoclaving or heating. Then you mix it ketoconazole or voriconazole, whatever it is. That's a 2% drop. But now it is available, so we don't use.
Yeah, I think before we conclude, we have 2 more cornea consultants, Dr. Swarupa ma'am and Nazreen ma'am. If you have any questions, Swaruprani ma'am. Even Dr. Nazreen is there. Any questions, ma'am, before we conclude?
Sir, are you seeing any
Good evening,
signs of
sir.
moxifloxacin resistance, sir, in future? Are you?
That's why. See now, Cipro 4th generation, a lot of papers published resistant to fluoroquinolones, particularly Pseudomonas. But that's why I said in vitro they may say, but in vivo when you treat the patient with your fluoroquinolones, if you see the response, hypopia level is going down, pupil is dilating, then patient, circumcranial congestion, everything, when conjunctiva is getting white, that means it's responding, you need not change. Then resistant Pseudomonas amphicaceae Tetracapta. Then even now there are reports, you know that Indian company from Chennai, they made unpreserved artificial tears, preservative-free multi-dose artificial tears. US, how many patients? Oh, they just, I don't know. I asked my friends, they said it's not due to drugs, sir. You know, people who have stored in commercial stores, it's all contaminated there, not from the manufacturing area, but somehow they all had Pseudomonas resistant to even carbapenem. Carbapenem resistant genetic mutation all happened due to this contaminated, unpreserved artificial tears. The multi-dose. In the US, now everybody will have the 15 ml multi-dose vials. It's a fancy thing. They will have a handbag. They apply like this.
Yes.
So wherever they go, they carry it and they contaminate. Unfortunately, all the products they have to withdraw it, and you can get without prescription. So, and also you had an epidemic of Fusarium after moisture loss contact solution. And the Acanthamoeba in Chicago in 2006 again on through the contaminated solution. Fortunately, India we don't have like this because India medical staff also they give, mostly they give steroids.
Yes.
But mostly they get from a ophthalmologist. And the system, of course, we have recent publications. Then you can go for colistin. There are so many antibiotics available, but still I believe in Cipro, Moxi, Evoflux. Tavramycin still is very good.
Yeah.
And chloromenical is still very good drug for
It works in most of the resistant cases, chloramphenicol.
They have published even methicillin resistant Staphylococcus respond to chloromenical.
Chloramphenicol, yes.
Sir, good evening, sir.
Dr. Nazreen Madam, sir, from Sankar Foundation Eye Hospital, Vizag.
Good evening, sir. Is there any role of intrastomal and intracameral antifungal, sir?
That's why I presented that you can give for deep fungal ulcer like deep stromal, 3 decimates, epithelium is covered. So you want to really deliver, you can give intrastomal. They repeat for 3 times, find one number you can give with 30 ml, 30 gauge needle. And I don't know, you have to go to theater or you will give a sleep time, I don't know. But some of us, they are giving. Intracameral, again, you can give, especially after TPK. Once you define, they just fill it into AC, amphotericin B also, they give. Subconjunctival also you can give. Publications from China, 14 injections they give subconjunctival with fluconazole, voriconazole, all those things. You can try.
We are trying, sir, intrastomal and intracameral. And what is the role of systemic antifungal, sir? How many days we have to give?
Don't give, but I think if I am correct, LUP they give routinely. These imidazoles, they routinely order for liver function test, renal test.
Sir.
So every patient, if you want to start, you have to do the renal function and the liver function. But I don't believe that. For corneal infection, best route is topical or subconjunctival or not systemic.
Interesting.
Unless they get endophthalmitis. It doesn't penetrate.
Yes, sir. Intracameral, what we have observed is, madam, sometimes when we do an AC wash and give this one, there is increase in the AC reaction next 40
Hypopyon is increasing.
Next 48 hours.
I don't know if it's inflammatory or we don't know. But some of our consultants, they give. I don't give, but some of
We usually don't prefer to go intracamerally, sir. Intrastromal in deep ulcers, as you told, we try with the 30 gauge needle and sometimes it works well, sir. But they need multiple injections, 2-3 injections they may require in 4-5 days gap. Once you have the healing edges, it's a sign that it's responding. and in those cases we try to give. Ma'am, Swaruprani ma'am, any questions before we come?
Thank you, sir.
చెప్పండి.
ట్రావెల్ మధ్యలో డిస్కనెక్ట్ అయ్యాను సార్. I just
Okay.
wanted to know
You are
about
seeing patients, huh?
No, sir,
PTM
ma'am is
keratitis,
traveling, sir.
traveling. That's why I
Traveling,
got disconnected, sir.
Okay.
In between, disconnected, sir. Hello.
మధురై రండి. లాంగ్ బ్యాక్.
Sure, sir. Sure, sir. తప్పకుండా వస్తాం, sir.
Come.
Yeah, please. Thank you, sir. I will come.
Thank you, sir. I think we are holding you back in the hospital.
Yeah, yeah.
No
Madhavi ma'am,
problem.
we can conclude it with vote of thanks from Madhavi madam. Yeah.
It's indeed a pleasure to have sir with us. It's an honor for us, and I thank you so much, sir, for sharing all your rich knowledge in cornea. The microbial keratitis is always a dilemma for practicing general ophthalmologist, comprehensive ophthalmologist. Thank you for sparing your valuable time. We are really holding you back, and thank you so much, sir. We wish to have you in person also for our conference. I think Dr. Madhu will have something chalked out for you for our next conference as well. And I thank all the panelists for actively participating, and the executive committee members and office bearers of APOS. Over to you, Madhu.
Yeah.
No,
Thank you.
and also we'll wish him a happy new year.
Oh, yes.
Happy New Year in advance,
Happy
sir.
New Year.
Thank you. Thank you.
On behalf of
Sir?
Yugadi is our new year. Don't say.
Yes, sir.
The
New
calendar
calendar
year,
years.
but for us, yes, that is.
Sir, but
24.
please, sir,
That is
please
the-
try to come to Tirupati, sir, next year.
Balaji is not inviting me. 2014 లో అక్కడ వచ్చినాను after my treatment.
Sir.
After that, I didn't come. మీ తిరుపతి మీ క్యూ వచ్చి just a bit.
Oh, no, we'll arrange
Kanaduga
you.
temple in Vijayawada, that's a good place.
We'll arrange for everything, sir, for darshan and everything.
Yeah, we'll see that Balaji wishes reaches you, sir.
Himachal is I was in twice.
Yes, sir. Yes. Vijay madam also went during the midterm conference, sir. Yeah. Thank you, sir. Thank you so much once again. Rajesh, thank you for staying back and helping. Thank you.
Thank you, sir. Thank you, Madhu.
Yeah. Good night. Good night.
Happy New Year.
Happy New Year to everyone.
Yeah.
Thank you. Thank you.
Bye, sir.